So case number 1, 41-year-old female with lupus nephritis and chronic renal insufficiency maintained on prednisone and candesartan, comes in for a routine clinic visit. Blood pressure is just a little high, a little bit of edema. K is 6.3, creatinine is 1.6. And the question is, which of the following would not be appropriate in the management of this patient? Talking about the hyperkalemia. Hydrochlorothiazide, discontinue candesartan, fludrocortisone, low potassium diet, or sodium polystyrene sulfonate, or whatever your favorite intestinal K binder might be. Okay, a little sluggish after lunch, I see. So the 6 people that answered correctly answered fludrocortisone, which is what I would say. So let's just run over this very briefly. So when I see a patient with hyperkalemia, I always ask, is it because of increased intake, decreased urinary K excretion, or shift out of cells? Recognizing that shift out of cells usually causes a transient hyperkalemia and not a prolonged one. If it's from decreased urinary K excretion, the urine K, if it's given, should be less than 40 in a day, 24 hours. Remember, 24-hour urine K is probably the measurement they'll give you on the boards. And the simplistic way of thinking about this is that the urine K excretion could be decreased either because they have renal insufficiency or they're just profoundly pre-renal, which decreases tubular flow, or because the collecting duct itself has a defect in K secretion. And that K secretion occurs because sodium is reabsorbed in exchange for K secretion, and that's stimulated by aldosterone. So all of these are causes of either adrenal insufficiency, blockade of the renin-angiotensin-aldosterone system, hyporeninemic hypoaldo, or drugs that specifically block that sodium channel ENaC. So in this particular patient, as you may have noticed, the hyperkalemia was multifactorial. As in many patients we see, she had reduced GFR, she was a diabetic, so she probably had some degree of hyporeninemic hypoaldosteronism, and on top of that she was on ACE inhibitors and ARBs. So in terms of what you can do for these patients, you reduce their dietary intake of K. You obviously try and stop the ACE inhibitors or ARBs if need be. You can't do anything about the renal failure. If they have hyporeninemic hypoaldo, if they have a normal blood pressure and volume, you can actually give them fludrocortisone. However, the vast majority of the patients we have with hyporeninemic hypoaldo are diabetic, and they look just like this patient. They're hypertensive and they're edematous, and so you can't give fludrocortisone. And so we increase renal K excretion, usually by giving them a thiazide or, if need be, a loop diuretic. And then, if need be, you can give these patients K binders. In the old days, when there was only K-exolate, you would give 5 to 10 grams a day orally, and that's low dose daily. You can get away with giving daily K-exolate. Nowadays, with the newer K binders that are coming on the market, there may be different strategies available. Okay. Next patient. A 48-year-old female was evaluated for several weeks of fatigue, nausea, and mild generalized abdominal pain. She's thin and tanned with a blood pressure of 90/45. Her palmar creases are hyperpigmented, and she has a serum K of 6.1, and labs as shown. Glucose is 40. And the question is, which of the following tests would be most likely to establish the diagnosis? Would it be plasma renin and aldo, serum cortisol at baseline and after ACTH, serum C-peptide, iothalamate GFR, or genetic testing for the sodium channel gene? Okay. And most of you chose B, which I agree with. So this is a patient that looks clinically like she might have adrenal insufficiency. The symptoms can include very nonspecific symptoms like abdominal pain, and sometimes these patients are mistaken for an acute abdomen. And the key is that they have sodium wasting and K retention and can be hyperkalemic. So B is correct. Next is a 26-year-old male with AIDS who's admitted with pneumocystis pneumonia and treated with prednisone and IV trimethoprim sulfur, which is Bactrim. On exam, his vitals are shown. He's tachypnic and has some RALs. And his K is 5.6. And the question is, which of the following would be the best treatment for this hyperkalemia? Would it be fludrocortisone, sodium bicarbonate, stop the trimethoprim sulfur and start pentamidine, stop the trimethoprim sulfur and start clonidine primaquine, or none of the above? Okay. All right, and so most of you spotted that you needed to stop the trimethoprim sulfur, but you weren't necessarily sure which drug to start instead. Turns out D is the correct answer. So the point is that, again, you've seen this many times. This is a collecting duct where the lumen is here. Tubular flow delivers sodium that's reabsorbed through the epithelial sodium channel ENaC in exchange for K secretion, and this is all stimulated by aldosterone, which is elaborated by the renin-angiotensin-aldosterone system. So most of you recognize that trimethoprim at high doses, like the IV trimethoprim we use for treating pneumocystis, can inhibit this channel and basically act just like amiloride or triamterene, the K-sparing diuretics. What may be less recognized is that pentamidine does the same thing. So they're both weak organic cations that substitute for sodium and block the opening of the channel. So you can't swap trimethoprim for pentamidine, but you can swap it for something else like Clindur and primaquine. Okay, next case, a 57-year-old female with end-stage renal disease, secondary to diabetic nephropathy. She's on chronic chemo, and she's seen on a non-dialysis day, and her K is 7.1. And the question here is, all of the following would lower the serum potassium substantially except. So is it insulin glucose, sodium bicarbonate, albuterol, sodium polystyrene sulfonate, or hemodialysis? And hopefully you all are familiar enough with multiple choice questions to recognize these except questions. David, how come this keeps blanking out? Yeah, it keeps going to sleep. Okay. All right, so most of you chose B, sodium bicarbonate, which is correct. So in a patient of hyperkalemia, if they have EKG changes, of course, we want to stabilize the plasma membrane of the heart with calcium-containing salts. Then we increase K entry into the cells, something that occurs over a matter of minutes. And the most effective is insulin and glucose, but beta-2 adrenergic agonists do so as well. The important thing to remember here is that if you're going to use inhaled nebulized albuterol, the doses that you're using are about 4 times the doses used to treat asthma or COPD. So if you use an asthma dose, you're not going to get much effect. Sodium bicarbonate is not very effective, and it's particularly been shown to be a poor efficacy in ESRD patients. I'll show that data in a second. And then you try and remove the excess K from the body with cation exchange resins, diuretics, or dialysis. And here's the study from Bloomberg that showed the efficacy of different treatments that were used in dialysis patients with hyperkalemia. See, obviously, hemodialysis is the best, but it takes some time. Insulin and glucose is pretty effective. Mean reduction K was 0.85. albuterol, or in this case, some patients got nebulized epinephrine, got a little bit, but sodium bicarbonate on average did nothing to the serum K. And that's why we almost never use it, except perhaps in patients who are severely acidotic. Okay, next, a 23-year-old male with diabetes mellitus presents with, let me just stop this, presents with 5 days of polyuria, polydipsia, and abdominal pain. And his K is 6.5, bicarb is 15, creatinine is 1.6, urine is notable for 2+ ketones. And the question is, which of the following statements about the total body stores in this patient is most likely to be correct? Total body potassium depleted, total body potassium overloaded, normal total body stores but redistributed into the extracellular space, normal but redistributed intracellularly, or none of the above. Sorry, let me click on that. Okay, so you're somewhat divided between A, which is total body potassium depleted, or D, which is normal total body potassium stores. And it turns out that A is the correct answer. Oops, did I stop that? Yeah. So in a patient that's having DKA, their potassium is shifted from out of their cells into the extracellular fluid, okay, because of lack of insulin. And these patients are having an osmotic diuresis. So this high extracellular fluid potassium is being excreted into the urine. So in fact, these patients are total body K depleted. And that's the case even though their serum K is high. So don't be fooled. Just because the patient's hyperkalemic, they're K depleted. And the reason you'll know about this is once you start giving insulin to try and shift K back into their cells, they become profoundly hypokalemic. So the true hypokalemia, if you will, is unmasked once you give insulin. Okay, next case. A 65-year-old female with a history of hypertension, diabetes, atrial fibrillation, ischemic cardiomyopathy, presents with a 1-week history of nausea, confusion, blurry vision, and hallucinations. Her meds are insulin, carvedilol, amlodipine, furosemide, and digoxin. EKG shows bradycardia, peak T waves, and a widened QRS complex. And her sodium is 134, K is 6, creatinine 1.9. And so the question here is, which of the following would be the most appropriate initial treatment for this patient? Would it be calcium gluconate, hydrocortisone, hemodialysis, digoxin-specific Fab fragments, or Digibind, or none of the above? Okay, interesting. Okay, so most of you chose, oops, let me stop that now. Most of you chose calcium gluconate, some of you chose Digibind. So this is a case of probable digoxin-induced hyperkalemia. So as you know, digoxin inhibits the sodium pump, and so K can't be restored into cells, so K is shifted from intracellularly to extracellularly and causes hyperkalemia. This only happens with severe dig intoxication and is an extremely dangerous situation with usually a very poor prognosis. So the clinical pearl here is that, so dig is obviously used in part in the heart to increase intracellular calcium. It's a positive inotrope. And it turns out that if you give calcium to these patients with dig intoxication, it's said to worsen dig toxicity. So most people would recommend that you avoid the calcium if you're reasonably sure this is dig intoxication, and go straight to the Fab fragments and give Digibind. So D is probably the better answer. If you suspect digoxin toxicity, it's best to try and avoid calcium. Okay, next, a 48-year-old male with hypertension ESRD underwent cadaveric renal transplantation. He's given ATG, mycophenolate, prednisone. Post-op, he's oliguric, and his K goes up to 6.5. He gets treated with K-oxalate and sorbitol as an enema, and 12 hours later he has diffuse abdominal pain. The abdomen's distended and tympanitic with hypoactive bowel sounds. And the question is, what is the most likely cause of abdominal pain in this patient? Is it ileus due to hypokalemia, stress-induced gastric ulceration, mycophenolate side effect, adrenal insufficiency, or colonic necrosis? Oh my, you guys are answering quickly. Lunch was good for you. And all of you chose colonic necrosis, which is indeed correct. So this was probably colonic necrosis from K-oxalate. So intestinal necrosis has been described with sodium polystyrene sulfonate, or SPS. They present obviously with abdominal pain, sometimes GI bleeds. It can be anywhere from hours to days after treatment with SPS. And it's usually elderly patients, vascular paths, ESRD patients, post-op or critically ill patients. Colon is most commonly affected, but other parts of the GI tract have been described. And in the pathology, you see SPS crystals, but the rat studies suggest that the major culprit is actually the sorbitol and not the SPS. Okay, 18-year-old females brought in after a suspected suicidal attempt, and unidentified pills are found in her pocket. And on exam, she is obtunded. Vitals are as shown. She's got a high heart rate, respiratory rate. She's febrile, and her bicarb is 15, and her arterial pH is 7.35 and PCO2 of 25. And the question is, which of the following is most likely to be helpful in this patient? Is it forced alkaline diuresis, IV ethanol, insulin drip, glucagon, or K-citrate? So you have to take an educated guess as to what this might be, because obviously there are no diagnostic tests here. Okay, but most of you picked up on forced alkaline diuresis, which I would agree with. So if you work through this, this is a case of primary metabolic acidosis with also a primary respiratory alkalosis. And if you do the delta-delta, it comes out to 2. So that's elevated, so it suggests there's a superimposed metabolic alkalosis. So there's a triple acid-base disorder. In addition, the patient's febrile, tachycardic, and tachypnic, and there's some evidence that she might have had a drug overdose. So if you put 2 and 2 together, you're going to suspect this is salicylate poisoning. And so you would probably start alkaline diuresis right away while you're waiting for the salicylate level and consider hemodialysis as well. And as we discussed earlier today, alkaline diuresis works to trap ionized salicylate ions in the tubule. So here's in an alkaline urine, it's in the form of an anion which can't be reabsorbed. When the urine pH is acidic, it's protonated and uncharged, and it can be reabsorbed back into the circulation by non-ionic diffusion. So the goal of the alkaline diuresis is to get the urine pH up and increase excretion of the salicylate anion. Okay, next case. 29-year-old female is found unconscious and brought into the emergency room. And her blood pressure is 105/67. She's comatose and has an alcoholic fetor. And her labs are remarkable for a bicarb of 11. Lights are as shown. Lactate is 1, CK is 20, serum osmolality is 300, arterial pH is 7.22, and PCO2 is 24. And serum levels of ethanol, ketones by the nitric oxide test, beta-hydroxybutyrate, and salicylate were all negative. So on the boards, there won't be too many questions where you have to do some extensive calculations, but every once in a while you come up with a question like this. I believe that on the computer they usually have a simple calculator for addition, subtraction, multiplication. And so I would encourage you when you get cases like this to use it to try and figure out what's going on. And so the question is, what's the most appropriate first step in the management of this patient? Is it forced alkaline diuresis, dopamine, fomepizole, thiamine, or hemodialysis? And here we don't have quite enough time to pause for everyone to calculate this, but hopefully some of you already did it before. Okay. But most of you recognize that this patient probably has one of the toxic alcohol poisonings and needs either fomepizole or hemodialysis, or both. So the key here is that you can't dialyze this patient without giving the drug to inhibit alcohol dehydrogenase. So the first step should be fomepizole. So if we work through it carefully, this is a pure metabolic acidosis and the pure anion gap acidosis. The delta-delta turns out to be 1. The osmolar gap, if you get out your calculator and calculate it, in this patient, the calculated serum osmolality was 266 and the measured was 300. So there's a huge osmolar gap. And so you're obviously going to suspect one of these 4 conditions. And propylene glycol only happens in hospital. So really 3 conditions: ethanol with ketoacidosis, and she did not have ketoacidosis, ethylene glycol or methanol. So it's either ethylene glycol or methanol. As it happens, because she has an alcoholic fetor, it's most likely methanol. But it really doesn't matter. If you suspect this, you need to start fomepizole on the patient to start inhibiting the metabolism of the alcohol to the toxic metabolites. Then you can worry about removing it, which almost certainly in this case would involve hemodialysis. So hemodialysis is correct, it's just not the first thing you would do in this patient. Okay. All right, next question. A 16-year-old male has a witnessed grand mal seizure and is brought into the emergency room. He is post-ictal and has vomitus on his shirt, and his blood pressure is normal. And his bicarb is 14, and let's see what else. Glucose is normal, CK is normal, osmolality is 289, urine and serum tox screens are negative, ketones are negative. So, what's the most appropriate next step? Is it alkaline diuresis, ethanol infusion, fomepizole, hemodialysis, or none of the above? Okay, so most of you said none of the above, hopefully because you didn't want to do anything. So this patient has an anion gap acidosis and a metabolic alkalosis. If you calculate it, it turns out he has no osmolar gap. And because the patient had just had a seizure, this is most likely lactic acidosis from the seizure. And as you know, that's very, very common immediately after a seizure and usually resolves in a matter of minutes to an hour or so. So the appropriate management of the acidosis here is to do nothing and check again in an hour or 2. Okay. Next, 48-year-old male in the ICU is intubated for respiratory failure due to severe pneumonia. He's paralyzed with vecuronium and sedated with lorazepam. He's hemodynamically stable, he's on no pressors, but consult is called because she's got a metabolic acidosis. His bicarb is 16, serum osmolality is 312, lactate is 8, pH is 7.4, PCO2 is 24. And this is the most appropriate next step: dopamine, dobutamine, get a CT scan of his abdomen, stop the vecuronium, or stop the lorazepam. Oops, sorry. Okay, so most of you recognize that you need to stop the lorazepam in this patient. So this patient has both an anion gap acidosis and an osmolar gap. Pretty unusual combination to see in hospital develop in a patient while they're in hospital. So the differential is alcoholic ketoacidosis, ethylene glycol or methanol, which we don't think should happen if a patient's already in hospital, or propylene glycol. And it turns out that propylene glycol is present at very high concentrations as the vehicle in Ativan drips. And it's metabolized to lactic acid, which is why the lactate level was high in this patient. Okay, next. A 78-year-old female has been in the ICU for 2 weeks because of cholecystitis, gram-negative sepsis, hypotension, ARDS, requiring mechanical ventilation. And the renal consult is called because of a persistently low bicarb. And her meds are imipenem, acetaminophen, dopamine, and noradrenaline. Her bicarb is 18, and lactate is 1.6, pH is 727, PCO2 41. So which of the following are appropriate in the management of this patient's acid-base disturbance? CT scan to rule out ischemic bowel, discontinue acetaminophen, add colistin to cover carbapenem-resistant enterobacteriae, alkaline diuresis, or A and C? Okay, good. So most of you chose B, which is indeed the correct answer, discontinue acetaminophen. So this patient has a pure anion gap acidosis, and he's on acetaminophen. And so as we discussed earlier today, acetaminophen actually depletes glutathione intracellularly and prevents the negative feedback inhibition of gamma-glutamyl-cysteine synthetase. So this metabolite accumulates and makes a lot of pyroglutamic acid. Now, this patient also had a lactic acidosis, but remember what we said, the lactate, if it's read out in millimoles per liter, gives you how many millimoles or milliequivalents per liter it should contribute to the anion gap, and it only contributes 1.6. So the anion gap acidosis here is not because of the minimally elevated lactate. There must be something going on. In this case, it's probably pyroglutamic acidosis, and the appropriate treatment is to stop the acetaminophen. Okay, next, a 65-year-old woman developed a staph infection of a prosthetic knee and was treated with vancomycin. She developed vancomycin-resistant enterococcus and then was switched to linezolid and treated for 6 weeks. And she comes in now with nausea, vomiting, and abdominal discomfort. And her bicarb is 14, creatinine 1.7, lactate 8.5, AST and ALT are normal, blood gas is shown. So the question is, what's the most likely cause of the acid-base disturbance? Is it seizure, drug-induced lactic acidosis, ischemic bowel, occult sepsis, or D, lactic acidosis? Okay, so half of you thought D-lactic acidosis and half of you thought drug-induced lactic acidosis. So let's see why you thought D-lactic acidosis. So patient's serum lactate was elevated, 8.5. The anion gap here was 19. So, which is about 9 above normal. So the lactate accounts for most of the anion gap. And remember, when you just check a serum lactate in the regular lab, that's L-lactate. So this is a true lactic acidosis. So there's no D-lactate, plus this isn't a patient with short bowel syndrome. So the question is really, why does the patient have lactic acidosis? Sure, it could be because of ischemic bowel, but there was no evidence for that. She didn't look septic. But she was on linezolid, and that's a well-recognized cause of type B lactic acidosis, meaning lactic acidosis that's not associated with impaired tissue oxygenation. So the causes of type B lactic acidosis, seizures, but only transiently, malignancies, particularly leukemias and lymphomas, and solid tumors that have extensive liver mets, liver failure in general, vitamin D deficiencies like thiamine deficiency, very rare, but beriberi can do it, and riboflavin deficiency. And then most commonly, there are a bunch of drugs and toxins that can do it, of which linezolid is on that list. Okay, next question. 28-year-old Asian female with a photosensitive erythematous malar rash and arthralgias comes into renal clinic. She doesn't vomit or have diarrhea. She doesn't drink alcohol. She says she doesn't use laxatives or recreational drugs. And her case, 3.2, bicarb is 15, urine pH is 6.5, urine sodium is 25, K is 35, chloride is 34. The most appropriate management for this patient is loperamide, hydrochlorothiazide, calcium carbonate, K-citrate 1 to 3 milliequivalents per kilo per day, or sodium bicarb 5 to 15 milliequivalents per kilo per day. Okay, good. So most of you chose D, which is indeed the correct answer. So this patient had a non-Gaap metabolic acidosis, the differential of which is shown here. If you calculate the urine anion gap, so here are urine lights again, sodium 25, K 35, chloride 34. So our urine anion gap was positive, plus 26. Therefore, this is a renal tubular acidosis. In the setting of hypokalemia and the malar rash in the female, it certainly suggests a type 1 distal RTA. And this patient did not have Fanconi syndrome. In the type 1 RTA, the urine pH is also always inappropriately elevated. And so that confirms the diagnosis in this patient. In terms of treatment for an RTA, in a distal type 1 RTA, all you're doing is giving enough alkali to neutralize the daily acid load. So the daily acid load coming from the diet is about 1 to 3 milliequivalents per kilo per day, not very much at all. In contradistinction to proximal RTA, where you have to give large amounts of bicarbonate to replace what's being wasted. So that's why 1 to 3 milliequivalents per kilo per day was appropriate. In a patient like this with low K, K-citrate would be a really good choice. Okay, next patient is a 54-year-old male with a 12-year history of type 2 diabetes maintained on insulin and proliferative retinopathy. He's referred for proteinuria, but he has a K of 6, bicarb of 19, creatinine of 1.6, and 3+ proteinuria. The most likely cause of this patient's metabolic acidosis is diarrhea due to diabetic autonomic neuropathy, diabetic ketoacidosis, solvent abuse, type 1 RTA, or type 4 RTA. Okay, easy. Everyone said E, type 4 RTA. So this is a classic example of hyporeninemic hypoaldosteronism. So these are patients who generally have mild CKD, but hyperkalemia way out of proportion to the GFR. And they have a type 4 RTA, so they have a non-Gaap metabolic acidosis. Their urine anion gap is positive, but they have a normal urine acidifying ability, meaning their pH can be appropriately low. And diabetes is by far the most common predisposing disease, as it was in this case. Okay, next, a 22-year-old male with HIVs who's on heart. He's on abacavir, tenofovir, and emtricitabine. And his K is 3.4, bicarb is 18, glucose 76, creatinine 0.4, calcium 8.6, phosphorus 0.9, uric acid 1.7. Urinalysis shows pH 6, 3+ glucose trace protein, urine phosphorus of 25, and urine creatinine of 38. The most likely cause of this patient's acid-base disturbance is HIV-related diarrhea, D-lactic acidosis, respiratory alkalosis with metabolic compensation, hepatic failure associated with RTA, or antiretroviral med toxicity. Oh my goodness, 100%, congratulations, finally. So E is indeed the correct answer. So this is a patient who's got hypokalemia, a positive urine, I don't know if I gave the urine anion gap, but hypokalemia and a non-Gaap acidosis that looks like an RTA, but has other features of Fanconi syndrome. So if you were to calculate the fractional excretion of phosphate in this patient, it would be 29%. But you also have the glucose. The patient has glycosuria. The serum phosphate is low. The patient's uric acid, I think, was also low. And so this looks like Fanconi's. In this patient, it was caused by tenofovir. Next, a 22-year-old female who presents with polyuric constipation and fatigue. She denies any prescription or over-the-counter meds. Blood pressure is 96/54. Exam shows only mild bilateral parotid enlargement. And her K is 2.9, bicarb is 38, creatinine 0.6, urine K is 17, urine chloride is less than 5. And the question for you is, what is the most likely cause of this patient's hypokalemia and alkalosis? Is it Little syndrome, Gittleman syndrome, Conn syndrome, diuretic abuse, or bulimia? Okay, so 2/3 of you chose E, bulimia, which is correct. Some of you chose Gittleman's, which is not correct because the urine chloride was very low. So remember, in a patient with metabolic alkalosis, the urine chloride is the best diagnostic indicator of volume depletion. And in a patient with vomiting, it should always be low. In a patient with renal chloride wasting, like Gittleman's or diuretic abuse, it's always high. So less than 25, surreptitious vomiting, greater than 40, diuretic abuse of Bartels or Gittleman's. Here it was very low, and so the diagnosis is surreptitious vomiting. Parotid enlargement is typical of bulimia as well. So that was the other clue. Okay, a 48-year-old male with congestive heart failure is seen in clinic for dyspnea and orthopnea. He has known systolic dysfunction of an EF of 20%. Is maintained on a bunch of usual cardiac meds. He's got crackles and edema, and his bicarb is 31, K is 3.5, arterial pH 751. Okay, and all of the following are contributing to this patient's alkalemia except metolazone, candesartan, hypokalemia, secondary hyperaldosteronism, or renal failure. Which one doesn't cause alkalemia? Okay, interesting. All right, so a quarter of you chose candesartan, which is actually the correct answer, and about 3/4 of you chose renal failure. And so this comes from a common fallacy, which is that renal failure always causes acidosis. Sure, under most circumstances it causes acidosis, but it's not an intrinsic feature of renal failure. What renal failure does is to impair excretion. Because most people in a normal, say, American diet that eat animal protein have net acid production, the inability to excrete that net acid production causes acidosis in most of our renal failure patients. Here, this is a patient who's alkalemic because of metolazone, hypokalemia, secondary hyperaldosteronism from the heart failure most of all. And in that circumstance, the kidney is trying to actually excrete alkali, but is unable to do it well because the GFR is low. So in fact, the renal failure is contributing to the alkalemia in this patient. Now, candesartan is the one that's not. So candesartan blocks angiotensin receptor, so it blocks the renin-angiotensin-aldosterone axis. So it has the opposite effect. It raises your K and causes a mild metabolic acidosis, usually not clinically evident, but sometimes it is in patients. I'm not going to go over that. Okay, next case. A 16-year-old male with muscle weakness. He's had several prior episodes that have resolved spontaneously. He doesn't think he vomits, and he takes no meds. Exam is normal, but his K is 2.8. His creatinine is 0.9. Urine sodium is 33. K of 48. Urine chloride of 72. So all of these disorders could be the cause of this patient's alkalosis, except, Okay, so Barther's, Gittleman's, loop diuretic abuse, thiazide, or surreptitious vomiting. See how many people still got it wrong. Okay, so this is surreptitious vomiting. Sorry about that. So the key here, yes. So the key here is that because the urine chloride is very high, this has to be renal K wasting, okay? So the only one of these that doesn't cause, renal chloride wasting, the only one of these that doesn't cause that is surreptitious vomiting, okay, where the urine chloride would be expected to be low. I apologize for that. Okay, we won't do that again. A 31-year-old male with a several-month history of acid reflux and heartburn is admitted with nausea, vomiting, abdominal pain, and confusion. He avoids seeing doctors and takes only over-the-counter meds, ibuprofen, omeprazole, calcium carbonate, and sodium bicarb. On exam, he appears a little dehydrated, abdomen's a little tender, and his labs are as shown, including a bicarb of 38. So the question is, what's the most likely diagnosis in this patient? Is it vomiting-induced metabolic alkalosis, hyporeninemic hypoaldo, primary hyperparathyroidism, milk alkali, or acute pancreatitis? Okay. Good. So the clue here is the calcium was high and the patient had some mild AKI. So this was clearly a case of milk alkali syndrome. A 54-year-old smoker with COPD, diabetes, and chronic renal failure is admitted with pneumonia. Overnight, he becomes progressively more obtunded. ABGs show a PCO2 of 78. He's intubated and ventilated, and 3 days later we're called because he's got persistent alkalemia and they can't wean him. And his bicarb is 43, creatinine is 2.4, pH is 7.64, PCO2 41. So the question is, all of the following would correct the metabolic alkalosis except acetazolamide, IV saline, decreased the minute ventilation, hemodialysis, or arginine hydrochloride. Okay, quite a combination of answers. So part of it is probably because the wording was confusing. So to that extent, I apologize. So what you have here is a case of post-ventilation hypercapnia. Post-hypercapnic alkalosis. Quite a mouthful. So these patients have chronic CO2 and bicarb retention, then they get on ventilation. So you notice this patient's PCO2 was normalized, but their bicarb remains high, and that's because there isn't enough time. Patient already has poor renal function, and or he might be dehydrated. So what you can do is to give these patients adequate hydration. You can try and increase excretion of bicarb with acetazolamide. You can always dialyze patients and correct alkalosis, and some people give arginine hydrochloride or hydrochloric acid. I've never done that. Now, decreasing the minute ventilation would correct the pH, right? So it would bring up the PCO2, but that wouldn't correct the metabolic alkalosis. In fact, it would decrease the stimulation for the kidneys to to get rid of bicarb, and so it would actually make the metabolic alkalosis worse. And so that's why C is the only one that's not correct here. Okay, just a few final questions. So here are 5 questions where each patient has a hyperchloremic metabolic acidosis, a non-Gaap acidosis. And there are 5 possible causes, and you have to select the most likely one for each of these stereotypic examples. And in the boards, they usually give you something very stereotypic. They don't generally try and trip you up. So a 38-year-old woman with dry eyes and polyarthritis. Serum K is 3.4, urine pH is 6.5, urine sodium, K, and chloride are as shown. Do you think it's A, B, C, D, or E? Okay, good. Most of you chose B, which I would agree with. So this is a patient who's got a positive urine anion gap, hypokalemia, elevated urine pH. So most likely a type 1 or classic distal RTA. The lights alone can't help you distinguish this from proximal RTA. In theory, you can sometimes see proximal RTA look like this, but being a woman with dry eyes and polyarthritis, and knowing that Sjogren's is the most common cause of distal RTA, makes B the most likely. Okay, next, 56-year-old Hispanic male with type 2 diabetes, diabetic nephropathy, serum creatinine 2.3. He's unable to tolerate ACE inhibitors due to hyperkalemia. His urine pH is 5, urine sodium is 43, K 13, and chloride 41. Most likely cause. Good, 100% for hyporeninemic hypoaldo. Which is exactly what this is classic for. Oops, sorry, not supposed to show you that. So a 26-year-old woman of osteosarcoma of the humerus, undergoing chemotherapy with ifosfamide. Serum K is 2.3, glucose 97, phosphate 1.5, and she's got pH of 7 for urine and 2 plus glucose. Okay, most of you chose A. So ifosfamide can cause both a proximal and a distal RTA, but the giveaway is the hypophosphatemia and the hypoglycosuria. So this is Fanconi syndrome and hence proximal RTA. 24-year-old man with type 1 diabetes, complicated by diabetic nephropathy, serum creatinine of 1.8, K of 3, autonomic neuropathy, chronic diarrhea, urine lights as shown. What's the most likely cause? So urine sodium is 10, K is 14, chloride is 36. Good. Most of you chose GI bicarb loss, so the urine anion gap here is negative, so the diarrhea is what was driving the acidosis. 21-year-old college student with a history of substance abuse. Serum K is 1.9, phos 1.5, urine sodium is 42, K 48, and chloride 12. Okay, good. And most of you chose toluene intoxication, which you can be fooled by. So they appear to have a non-Gaap metabolic acidosis, but they have a positive urine anion gap. And that's in part because some of them have an RTA, but also because hippuric acid, the hippurate, is excreted in the urine, and they often have severe hypophosphatemia.